So it's 8 o'clock. I want to get started because we have a lot to cover today. So I would like to introduce the session tonight. My name is Cindy Wu. I'm the outgoing lead next generation editor for ASJ. On the call with us is Ryan Austin, who will be taking my place, and he'll be continuing to moderate the Journal Club. So welcome, Ryan. And tonight he will be polling the audience during the slide deck presentations to start thinking of your questions, because we want to make the most of the hour. So tonight, we want to welcome our two moderators and authors, so Dr. Michelle Spring and Dr. Karol Gutowski, and they are going to have a point-counterpoint discussion on how they prevent seromas and abdominoplasties, and they have some really good practical tips for those in the audience as well. So to introduce Dr. Michelle Spring, she currently practices at Glacier View Plastic Surgery in Kalispell, Montana. She's currently the Vice Chair of Surgery at Kalispell Regional Medical Center. Prior to this, she practiced in Marina del Rey and was Adjunct Clinical Assistant Professor of Surgery at USC. She did her plastic surgery residency at University of Wisconsin and then completed an aesthetic fellowship in Marina del Rey and a cleft and burn fellowship with a nonprofit agency called Resurge. She's going to discuss her paper, The Use of Lysine-Derived Urethane Surgical Adhesive as an Alternative to Progressive Tension Sutures in Abdominoplasty. Dr. Karol Gutowski is on the call with us tonight too. He practices in downtown Chicago in Oak Brook. Prior to this, he was the Chief of Plastic Surgery at Ohio State, on faculty at Pritzker, and Chief of Aesthetic Surgery at University of Wisconsin. He did his plastic surgery at UT Southwestern, followed by a fellowship at NYU. And Dr. Gutowski is going to discuss his paper, Reduce Seroma Risk in Drainless Abdominoplasty Using Running Barb Sutures. So for those of you who are joining us via audio, please type your questions in the chat box at the bottom of the screen, and that's where you'll find Ryan. He'll be polling the audience about how you practice. Or you can email the questions to Phaedra at Phaedra, P-H-A-E-D-R-A @surgery.org. And for those who are joining us via audio, then you can also email her via your phone, and we'll curate the questions. So, and for people who aren't able to join tonight, we're going to record this, and it'll be on the ASJ website and the YouTube channel. So first, I want to introduce Dr. Spring, who will start with her slides. And if we could have those slides up, please.
Are we starting with Dr. Spring or Dr. Gutowski?
Oh, I'm sorry. It's Dr. Gutowski's slides. And then we'll go to Dr. Spring. Apologies.
I'm going to share my screen. Bring these up.
Okay. Can you hear me?
Yes.
Can you see the slides okay?
Perfect. Thank you, Cindy, for the introduction, and welcome, everybody. I'm going to start off with a paper that is a large series of among two surgeons of progressive tension sutures to eliminate drains and abdominoplasties, and this is really built on work that's been published before in this journal. There have been other series also confirming it, but this is the first one that looked at two different practices and kind of how it all evolved for us. So I would like to thank Dr. Alan Rosen in New Jersey. We're the two that first published this probably about 10 years ago in different journals, just a few months apart. Next slide. So, next slide. So why eliminate drains? I think a lot of us know that our patients don't like the discomfort of them, the additional nuisances that come with them, the risk of infection and things like that. And I think we have to question, do we really need to be using them in many body contouring procedures? And some time ago, Greg Evans did a good meta-analysis and review of the literature, kind of questioning where do we really need them? And there really weren't a lot of studies supporting their use in cases that we commonly use drains in. Next slide, please. And even our professional societies have looked at this and quite some time ago determined that, for instance, for breast reductions, there is no evidence for using drains. But despite this, even in this year, I've heard of people using drains and breast reductions for anywhere from overnight to up to a week. without any real evidence for it, but it certainly does cause patient stress, discomfort, and other problems. Next slide, please. So what's the patient's perspective on this? Well, if you go to Real Self or any kind of other chat rooms where patients talk about it, they don't want drains. They're looking for options. They're afraid of them. In my practice, people seek me out just because they're looking for no drain tummy tucks. And so I think we have to listen to our patients if there's no evidence that suggests that the drains actually make a difference, and if there's a way of eliminating them. Next slide. So some time ago, there was a good review of the literature on tissue adhesives published in our journal, and it really showed, at least at that time, we didn't have good data to suggest that the adhesives are going to make a difference, especially if you eliminate the drains and rely on the adhesive itself. However, Dr. Spring was able to do a study on a novel adhesive, and that's when I'm going to turn that over to her, and she's going to talk about her paper.
Thanks, Carl. Thanks, everybody, for being here. I look forward to a good discussion about drainless tummy tucks after we're done with the slides. I'm going to talk specifically about a small study I did on a synthetic urethane tissue adhesive compared to progressive tension sutures. Next slide. So here are my disclosures. Unfortunately, the tissue glue, Cohera tissue glue, is no longer on the market, but we thought it was still worthwhile to talk about this study and sort of how the product fits into the overall idea of drainless abdominoplasty surgery. My other disclosure would be that I learned how to do tummy tucks without drains from Dr. Gutowski in about 2006 when I was one of his residents in Madison, Wisconsin. So I decided from there on out that I was never going to use drains again for tummy tuck surgery, and I never looked back. Next slide. So basically, I did a very small prospective study, 20 consecutive tummy tuck patients, 10 with progressive tension sutures and 10 with this tissue adhesive. The patient demographics were very similar. Both groups had patients with BMIs up to 33. Both groups had a massive weight loss patient. Next slide. The comorbidities and past abdominal procedures were, a smattering of various things, so they were pretty similar as well. You can go on to the next slide, please. This is a schematic of the progressive tension sutures versus the pattern from the tissue adhesive, and I tend to use about 15 2-ovicral sutures when I do progressive tension sutures, and that's approximately the placement. Next slide. The results from the study, it's a lot faster and easier to use the tissue adhesive. It takes about 30 seconds to place, and then I held pressure for 5 minutes for all the patients. I can't remember if the package insert said 3 minutes, but I just made it consistently 5 minutes, and I can place the PTS sutures in about 11 minutes per patient. Complication-wise, neither of the groups had any seromas. Both groups had a few small wound complications and suture issues, not anything that was abnormal, in tummy tuck surgery. You can, next slide. So for me, the study, kind of the tissue glue take-home message for me was that I miss it. I really liked using it. It was a lot easier and faster than placing the progressive tension sutures. But even when the study ended, I didn't continue to use it because it cost $500 per application, and I just couldn't justify using that instead of vicryl sutures, which in my hands have the same result as the tissue glue. So I think it really reinforced to me that subsidized products and devices need to be disclosed by us surgeons so we can really all evaluate how cost plays into the treatment. And maybe somebody in the audience knows more than I do about why the tissue glue is off the market. I surmise that the high cost of the product resulted in poor utilization. Maybe it was the very narrow FDA indication for only abdominoplasty surgery. Are we all reluctant to learn new techniques, and a lot of people don't want to stop using drains. So next slide. And in general, for drainless tummy tuck surgeries, I don't use drains. I never have since I trained. I have a very low seroma rate. I only look for clinical seromas, a visible or palpable fluid wave. I personally don't tumesce the flap. I sharply excise subscarpus fat. I flex the patients during closure. I keep them hunched over for about a week, and then I have them stand up straight. I even move them in a flex position from the OR table to the recovery bed. And I'm very strict in limiting activity and having patients wear a binder for 6 weeks. I actually think this is one of the most important parts of my regimen, at least. My staff knows to reinforce that with all patients at their post-op visits, and I do see them pretty frequently at first after surgery. So I think I'm going to hand it back over to Karol to finish the slides.
Well, I think Michelle brings up a lot of great points, and I wish this tissue adhesive was available because it probably is a lot easier to use than progressive tension sutures. You apply it and you hold pressure, whereas the progressive tension sutures do take a little bit of work, and you're working in a deep hole on the undersurface of the flap. So when a good adhesive comes, I think we're going to welcome it. But as Michelle also brought up is the cost, and $500 for most practices is a significant difference. It can make up 3 to 5% of the cost of an abdominoplasty, and patients may be affected by that. So I think the companies that make this have to realize that. And I think what Michelle said is when you look at these studies, when there's an intervention like adding a new product, a glue, a suture, what have you, surgeons may be happy with it, but when there's a cost involved, that may not get really talked about until you try to implement into practice. Barbed sutures, my understanding, are between $10 and $20 a packet. I typically use 2 of them for the progressive tension sutures, maybe a third. So you'd be maybe talking between $30 and $60, and maybe the additional 8 to 12 minutes of OR time as opposed to a drain. If you look at the costs of drains and bulbs, it probably is offset by the cost of the sutures. So the financial burden of using progressive tension sutures, I think, is pretty low compared to the drains. Michelle, I got to congratulate you for having a very low seroma rate. That's fantastic. I actually do have a very low threshold for sticking a needle in and seeing if there is a fluid collection. And we do have an ultrasound in our office right now. Just for fun, I started looking for seromas. And of course, the more you look for them, the more you find. But they tend to be insignificant, a few cc's, and are generally not worth aspirating if, like Michelle said, there's no fluid wave. And clinically, if you can't detect it, it's probably not worth looking for it. So let me just kind of explain how I do it. I think Michelle did a really good job of explaining how she does it. Next slide. This is just a diagram, and this is in the Aesthetic Surgery Journal a few years ago when we first published it. I draw some lines for the first few times so that people can learn from it, and I put my progressive tension sutures in. They're double-ended barbed sutures. They start superiorly, go to inferiorly, following those lines right there. Next slide. And that's just demonstrated on the table. The patient is flexed, just like Michelle. We flex the patient as we do it. And I do draw these lines just as an educational opportunity when I work with residents or to show other surgeons so that you don't pull the flap to one side or the other. You want to keep those lines lined up as you drew them. Next slide. Now, one thing that's important is adequate compression. And Michelle stress the importance of a abdominal binder for 4 to 6 weeks. I've been using it longer and longer, but what I changed is I got rid of the binders that tend to ride up and not cover the lowest part of the abdominoplasty, and I started using just very high quality liposuction compression garments, not binders, sometimes a abdominal binder over it, but also the use of some sort of foam, whether it's toppy foam or something else, and that does reduce swelling, bruising, and adds additional compression without being uncomfortable. And I usually use the foam in there only for a week. Next slide, please. So the complications rate in our series, and this was Dr. Rose and myself, we kind of independently came up with this. You'll notice his seroma rate is lower. And what he told me is as we run 4 strands of progressive tension sutures, 2 on each side of the midline, he added another strand over the midline to eliminate more of the dead space, and after that, his seroma rates dropped off quite a lot. So I think one learning point is we do this differently, but if you read the paper, he added that additional suture line down the middle, and that reduced his seroma rates. But most of ours have been just small seromas, needleless aspirations, and very rarely did either him or myself had to put a seroma cath in, which I still don't consider a failure, because if less than 2% of your patients are getting a seroma cath, that means 98% are not getting a drain. And a seroma cath usually stays in for a few days. It's not a full week or 2 weeks, and it's not as burdensome as a typical JP drain. And if you look at the other things, they're not going to prevent hematomas, so that's, of course, not a problem. It's not going to prevent wound dehiscence, DVTs, anything like that. Next slide, please. So just some practical tips. I think if you're going to start doing this, if you're going to use barbed sutures, you want to make sure the people that are assisting you in surgery are familiar with how to use them, and so they don't mess anything up with the suture. You have to be a little bit more careful with them. Avoid any contact with gauze or sponges because they'll pick up the lint. There's additional needles then on the table, so you have to be careful with that. And if the suture does break, which rarely happens, all you have to do is start with a new one approximately 3 to 4 centimeters proximal to the old one, just overlap, and it'll keep going. Next slide. As I said, make sure you don't pull the flap one side or the other, otherwise you're going to have a deformity afterwards. So use the markings as I showed you. Don't do too much tension when you do your final closure. You may get a little fat necrosis. The barbed sutures are supposed to approximate, not strangulate. And I do use this on my body lifts and circumferential abdominoplasties, and you can even use the sutures to do 3-point fixation to close off the dead space posteriorly, and you don't have to place a drain there either. I would advise the patients that they may see small little dimples in the abdominoplasty or in the abdomen that resolve within 1 to 2 weeks if they're particularly thin, and those progressive tension sutures may have pulled the skin or puckered it a little bit, but they always resolve. Also, a few weeks to a few months later, as the sutures start dissolving, patients may feel a little popping sensation. Just warn them about ahead of time so that you don't get any phone calls about it later. Next slide. So that's it for my presentation. I will hand it back to Cindy.
Yeah, thank you both for your excellent presentation. I want to just ask the audience to kind of look at the chat box during the slideshow. Ryan has posted some questions. We tried to do a poll, but for interest of time, we're doing it this way. So we just want to hear from people. What are they doing for their abdominoplasty? If you want to kind of unmute yourself and explain what you do and why. Are you using drains, progressive tension sutures, tissue adhesive, or other? That was kind of the first question to the audience. And while you guys are thinking about that, we did have a question directly to Dr. Spring from someone in the audience. And the question was, Dr. Spring, are you that strict about flex position with progressive tension sutures?
I can't.
Can you ask the question again? Do I always flex patients?
Yeah, I think the person, and if they want to chime in about their question, are you that strict about the flex position, as strict with the flex position with progressive tension sutures, as you are with the glue?
Yes, I am. When I did the study, I wanted to compare the tissue glue to the exact way that I was using progressive tension sutures. So I am pretty strict with, doing it the same way each time. If they don't walk hunched over, I'm okay. I try to remind them to do that, but at least like the transfer on the bed and when I close the patient, I have them in kind of a mild beach chair position.
Interested to know, is there anyone in the audience who doesn't flex their patient at any point during the tummy tuck, or is everyone pretty much doing that? Okay.
I always flex.
Yeah. Okay. And then
It's
just
amazing Biden is doing so well in Massachusetts.
Right. And great that he's doing so well in Alabama.
Someone needs to mute.
Oh, okay. I thought that was an answer. Okay. Is
I,
there anyone in the audience doing drains, or just strictly drains? No progressive tension sutures, no adhesive. Well, I guess that's no longer.
I'm just doing drains, no progressive tension sutures. This is Andrew Cohen.
Okay. Do you put, how many do you put? Are you putting one or two?
I put 2 drains in, and earlier, do you mind if I mention the glue a little bit of why it's probably off the market?
Please.
please.
It's off the market because the Cohera glue is horrible. I would not recommend it to anybody. It doesn't dissolve and can cause infections. I had to take care of a patient at Cedars-Sinai recently, and most likely, probably there's other patients out there, I don't know, but I've tried to talk to the company and the rep, and they continue to say, "Oh, we've never heard of this before," but it was horrendous. It was infected tummy tuck from the glue. The glue didn't dissolve. I had to go in and open it up and remove pieces of undissolved glue. So I honestly think that's why it's off the market.
So if I can speak to that, I've probably done about 50 cases with the tissue glue. The learning curve for me was that when the glue is too close to the incision, it can extrude just like vicryl sutures. So I would stop, the adhesive a couple centimeters above the incision line, but it can also coalesce if you're not careful to keep the dots separate. And
Right.
they coalesce and drip and form together, it can form like an actual rind. So I think maybe people did have problems with that, where you're not getting healing tissue in between the drops. You have to be really careful about, putting the drops. But I probably did 40 to 50 cases, and I never had any problems other than some extrusion through the incision, just like vicryl. So I don't doubt that has happened, but it wasn't a problem when I used it, and I would use it today if it were on the market because I did like it.
I'm not sure. Another doctor placed it. I was just taking care of the problem. So I don't know how it was placed. It may have been too much and done incorrectly. So you may be correct.
Yeah, and no,
I see some questions about binders and blood supply to the tissue, and also people not moving, restricted movement after. And I just want to clarify, at least for me, I restrict people from working out. Everybody wants to, as we all know, go back to yoga and jump on their horses and do whatever they do. What I'm talking about restricted activity is not doing that. So I encourage people to ambulate and move around. So I saw that as a question I wanted to comment on.
And I'm with Michelle on that. I let people get back to activity. They're up walking around the same day because we do tap blocks and a few other things. So my patients are walking around the same day. But yeah, they're not working out until 3 or 4 weeks later, but I certainly don't have them at bed rest or any kind of crazy restrictions about moving around. They're moving.
And then there was also mention of compression garment, curious to know what people are doing, the standard hook and eye closure stage 1 garments, are people doing that, or are they doing more garments without those? And if you use foam, if that's something you incorporate with your regimen, if someone wants to weigh in on that, because that's an important part too.
I've used those binders that have the 3 different adjustable bands, which I love, but now I'm just on the cheap hospital binders. So I use whatever someone gives me, and that seemed to have the same outcome.
Yeah, and just looking at more responses, there's Dr. Charles Chalexon had a comment about the waist lipo puts more patients at risk for failure with fluid. Can you clarify
I would say no. I've been doing tumescent analgesia probably since, I don't know if Michelle, when you were with me, I always tumescent the abdomen with a couple liters in the flanks, another liter, just for post-op analgesia and hemostasis, whether I do lipo or not. And I do lipo in about 95% of my abdominoplasties. That fluid is not an issue. Absolutely not. It does not increase seroma rates.
Okay, and then Dr. Saheb Al-Zamani, you had a question. Do you want to ask your question for the group or for the authors?
Sure. My question was regarding the abdominal tissue glue. I was wondering whether you found that there was a little bit higher migration of the final suture scar line when you were using the tissue glue compared to when you were using progressive tension sutures. There's just one of the post-op images from the paper seemed to show that the scar line was ultimately sitting a little bit higher with a bit of elevation of the introitus with the tissue glue patient as compared to the progressive tension sutures. And I just wanted to see what your experience was with that.
I don't think it had to do with the glue. You know, I usually do 3-point sutures from the incision down to the fascia to try to, you know, not allow that incision to go up as much. So I did that for all of the patients. I think that's just was technique. Yeah, I haven't noticed a difference from that standpoint.
Do we want to jump in with Dr. Austin and have him go through some of the Q&As that he's been doing?
Yeah, so it seems like we're getting a fairly broad response with people's experience and what they're using with private messages and what you can see in the group. It seems like there's a mix between people who are using drains, people who are using some drains, and some progressive tension sutures. I mean, for the people out there who are using drains and have tried progressive tension sutures and are still kind of waffling back and forth between, are you choosing those based on individual case or patient-related factors, or is it are you hesitant to kind of make the full leap away from drains over to progressive tension sutures? I'd be interested to know.
And you can unmute yourself if you'd like to respond. Thanks.
Dr. Tuma, you like me, I'm hesitant to take the leap. I want to take the leap. So can you elucidate some of your thoughts about still using a drain? Because I probably have similar ones.
Yeah, so I just think, you know, you're really a product of your training, and depending on your generation where that lands a little bit. I definitely think the drains come out faster with the progressive tension sutures, so I am heading in that direction. I just haven't really made that leap yet.
What I tell people is try this if you do trams or abdominally based breast reconstruction flaps, and you're going to keep those patients in the hospital for a day or two anyway, or 3. Try it on those patients first, and then you'll feel much more comfortable because you're going to round on them every day, and you'll see that there's no seroma. And then transition that to your aesthetic patients.
I think that's a great advice. You know, certainly that's much easier to digest, but you know, the problem is that the seroma in these patients, although it sounds like most people could say that they're small, certainly we've all experienced those difficult patients who, you know, you're aspirating every week, and even with drains, certainly that happens. So it's just a tough leap for me personally. I know there's a lot of data out there to show that it's a viable option, and I'm definitely leaning in that direction. I just got to take the big toe and dip it.
Yeah,
I want to just reemphasize, for me, I think I can't emphasize enough from how I do it, at least, and everybody probably does it differently, is how important I do think compression for a longer period of time is. Ironically, I had the first seroma I've probably had in 5 years a month or 2 ago, and someone in my office had told the patient she could take her binder off after 2 weeks, and she was a roofer. So I think, you know, it probably has less to do with what we're doing, and maybe a little bit more to do with how much fluid they're producing and how active they are and stuff. So for me, it might just be anecdotal, but I feel like the post-op regimen is equally as important as, you know, drains or stitches. And I probably put in more sutures than a lot of people do. I put in, you know, a good 15 sutures, and I've also done barb sutures like Karol does, and I just get all confused with all the needles.
Michelle, do you leave a little bit of fat on the abdominal wall fascia, or do you go straight down and just see all white fascia when you lift your flap up?
I always intend to leave some down, and then by the time I'm bovieing on 50-50, it just never happens. So I don't. I try to. I think it would be a great idea, but I get going and then I don't.
because that's another thing. There have been some papers showing that if you do cold dissection with a scalpel under tumescent analgesia, you're probably creating less liquefying fat. And then also if you leave a little bit of fat down on the abdominal fascia, so it's that white glistening layer, but a little bit of fat down, when you put your abdominoplasty flap back down, it may adhere better and therefore have less chance of a seroma. So there are some other little techniques, and probably beyond the scope of this journal club to really review all the abdominoplasty seroma prevention techniques, but there are some things that can be done to keep reducing that rate more and more.
So Dr. Tuma, your question about higher BMI patients, for the audience, are people, what is your cutoff for BMI for a tummy tuck patient? And if you are operating on people with higher BMIs, are you doing anything different to prevent seroma? So thanks for that question, Dr. Tuma.
I do high BMI patients because I do a lipo-abdominoplasty, so I'm pretty aggressive with the liposuction, and I would agree they are at a higher rate for a seroma. I see them more frequently, and I just do needle aspirations right above the pubic area and see what happens. But a high BMI in itself, in my practice, is not a problem.
What do you consider high?
That's a good question. To me, it depends on how much loose skin they have. I've done people with a BMI above 35. If they've got a lot of loose skin and they're at the weight that they're not gonna lose any more weight, they've got to overhang a pannus. I think it's fair to do. We have a reasonable discussion about the risks being higher. No one's ever said no.
Karol, do you just automatically kind of tap a presumptive seroma with the more overweight patients, or are you looking for a clinical?
I look for a fluid wave like you, but I've also found some, especially the massive weight loss patients, their skin is kind of floppy anyway. And sometimes when I'm looking for a fluid wave, I can't tell, is that just swollen loose skin or is that really a fluid wave? So they're numb in that area anyway. I just give them a little bit of local anesthetic. I put in an 18 gauge needle on a 10 cc syringe and I check. And then if there's nothing there, I'm happy. I don't worry about it.
So we have some comments about either individual sutures for PTS or running barb sutures. We'd be interested to know, for the people who do the individual sutures, what do you use? And then about how many do you put in and how long does that take?
Michelle, do you do the individual?
Yeah, I've gone back and forth a bunch, but now I'm back. I'm doing Vicryl sutures. Yep, just 2O Vicryls. And I put them in, and I figure about maybe 2 to 3 inches in between sutures. I make sure that I can put 2 fingers in, but not a lot more than that. So I just sort of space them out.
Now I have a question. Is there anyone who does running suture with like a 2O Vicryl, not a barb suture, but a running Vicryl to do the progressive tension to, cut costs? And for those people who do it, is there a difference? Have you used one and then gone back to barb or back and forth? Or no one? So
after having done both, I think it might be hard to do running Vicryls if it doesn't catch. I don't know what you guys think, but if the barbs don't catch.
Yeah, I've always done a running progressive tension with a barb, and I find that you need it just to get the just to minimize the amount of bite that you get on the anterior flap, to try and minimize the dimpling while still retaining that strength and actually offloading the kind of tension from the flap and advancing it down.
Okay, and then, so let's talk about compression garments versus binders. I know that people have their own practice patterns, and then some people also add foam. So I'm just curious about the audience, whether there are people who don't use compression binders or garments. So pretty much everyone has some sort of external garment, sounds like.
Absolutely.
Yeah, okay.
I'm just looking back. It looks like Dr. Molliver was talking about his hesitancy to apply binders. So I don't know if he's using them or not, or.
Yeah, Dr. Molliver, are you on the call?
I don't see his name. He may have dropped off.
Yeah, some people, I mean, there have been papers in the literature about how compression garments and binders in the inguinal area can cause compression on the veins, on the iliac veins, thus increasing your DVT risk. So that might be a reason why he doesn't use them. And as we know, abdominoplasties itself has an increased DVT risk. So I can understand the rationale for that.
I've had a few patients who were a little, now I mark, if I do use a binder, I mark how tight it should go. But I've had a few patients whose family members have gotten a little too aggressive at home on tightening them. And then you get a phone call that they're short of breath and you're thinking, oh my God, are they having a PE? And you have to tell them just undo the binder right away. And within minutes, they're back to normal. And that's one reason I kind of went away from binders is I think they don't distribute the tension very well as opposed to a compression garment, which can be properly fitted and the tension is distributed much more evenly.
And Dr. Gutowski, can you inform us of how you measure patients if you have both that compression garment and the top of foam? Because, you know, that adds additional width to the patient, basically. So preoperatively,
Yes.
Are you measuring them the same, or do you have like afford a couple centimeters for the foam?
Good question. So I have an awesome patient care coordinator who measures everybody, but she follows the guidelines of the company's the company measurement guidelines, and it's always been right on. And because I always do liposuction, if I am going to reduce the bulk a little bit, and then if I add the 1 centimeter foam, it seems to work really well. So we just measure as we see them, and then do liposuction, put the pad in, or the foam pad in, and it seems to, I've never had a problem with being too tight or too loose.
We have a comment regarding the barbed sutures for PTS having more overall tissue swelling. Has anyone encountered that use barbed sutures?
I know I've stayed away from them near the skin. You know, I think they spit a lot, but I don't know if that has to do with tissue reactivity or just too close a placement to the skin.
Yeah, I find that if I run almost a deep subcutaneous barbed suture, but if you get that too close to the upper subcutis or the dermis, you can start to get wound breakdown, and then you're pulling out a whole section of that stitch as it breaks down.
We have a question that came into me from Dr. Charles Chalixon. Do the authors think that patients who have concomitant lipo to the waist have higher issues of seroma? He personally does.
I don't.
I don't either. I do liposuction on almost every abdominoplasty, and it doesn't make a difference.
Thank you.
Okay, Ryan, were there any other questions that we didn't get to from the audience? I'm scrolling through the feed, which has been really very active. So thank you everyone for putting in your comments and your rationale, because I think this is how we learn, and this is the whole point of the journal club. So we appreciate all that. And feel free to unmute yourself.
I mean, like we got to most of the comments, which is great. I gotta, thank you guys for all writing in either to the group or to me. If anybody didn't have their question answered or has anything burning, feel free to bring it up now. But I think that Cindy, we have gotten to kind of the gist of everything.
Okay, great. So, I'll just wait for a little bit for any last minute questions, but I just want to remind everyone that this is being recorded. So if you have friends who couldn't make it, it's available on the ASJ YouTube as well as the website. You scroll all the way down, and then all of our journal clubs are recorded, so you can look through them. They're also edited. But let's see. Yes, thank you, Dr. Tuma. So yeah, thank you everyone for participating. This has been a really great discussion. Thank you for tuning in and your questions and the active discussion. So we'll have this every Tuesday of the month, the first Tuesday at 8 p.m. of every month. Next Tuesday will be hosted by YAPS. And yeah, join us then. Thank you, everyone. Have a great night.
Much.
Thank you.